Welcome everyone to Arthritis at Home. My name is Ellen and I'm the programs coordinator. Today I'm joined by Dr. Claire Barber, who is an associate professor in the Department of Medicine and the Department of Community Health Sciences at the University of Calgary and a research scientist with Arthritis Research Canada. Welcome, Dr. Claire Barber.
Thank you. It's a pleasure to be here.
Dr. Barber, I do want to congratulate you on the award that you've won, which we'll get to learn a bit about that research project today.
Great. Thank you so much.
So first question for you, Dr. Barber, is can you tell us a little bit about yourself and how you're involved in rheumatology?
Oh, that's a great question. So I started off in the East Coast in Halifax, Nova Scotia, and I went to Dalhousie. I did an undergraduate degree in microbiology and immunology, and then went to medical school in Dalhousie. And very early on in my medical training at Dalhousie University, there was just a tremendous group of rheumatologists, and we do musculoskeletal training. So we learn how to do joint exams that are facilitated in partnership with patients who have arthritis and the rheumatologist to learn, how to do these physical exams and take histories from patients. And I have to say that was a really formative experience for me, and I learned a lot and worked with Diane Mosier, who at the time there was my preceptor, and she encouraged me actually to do research with John Hanley, who's a rheumatologist there who focuses on lupus. So I ended up getting a summer studentship through the Canadian Rheumatology Association to do research, very early on in my career. And that sort of paved the way for everything that came forward. So it was really, incredible mentorship along the way, and also that early connection with patients to really kind of understand what living with arthritis and other autoimmune diseases meant to them. I think it was really impactful in forming kind of the basis of my career.
That's incredible. I think it was, the right moments, the right people. We're glad to have you in rheumatology. Very, very glad.
Yeah, well, it's such a privilege every day.
Awesome. Dr. Barber, do you mind if I ask you to kind of take us through your research project and then maybe how this came to be? Because I know that your research is in quality improvement. Let me know if I'm incorrect.
Yeah, no, that's great. So yeah, this has been, this project has been, again, it's not just myself, there's many other co-applicants. We have patient partners, colleagues in research at the University of Calgary, as well as the University of British Columbia. We have academic kind of research-based rheumatologists and many community rheumatologists, as well as some pediatric colleagues as well. So this has been really a great collaboration amongst, many tremendous colleagues and patient partners. So the title of the project is really on how to develop and pilot a shared care model for rheumatoid arthritis and leveraging what's called an on-demand follow-up strategy. And this has been something that, again, I've been in practice just over 10 years and doing research, longer than that through my medical career as well. That's been sort of something I've been thinking about in the models of care and how we deliver care to patients. We all know, especially in rheumatoid arthritis, we need to get patients into care very early in order to get a proper diagnosis, ensure that people are on appropriate treatment, and then we need to follow that care along the trajectory of along with the person to make shared decisions about the types of treatment, assessing the treatment response, and making sure that we get our patients, not only in low disease activity, but meeting all of their needs along that journey. And the tricky thing is that the way that our medical systems are set up doesn't always, adequately address this. So often people come in, we try and get people in as quickly as possible. Then they're seen kind of once you make a diagnosis, you start treatment. And then often it's sort of a decision, and it's often based on scheduling to see people at 3 or 6 months, or sometimes even 12 months if they're very stable. But patients with arthritis will tell you that their disease flares in between these visits, or they have challenges or questions or needs in between these visits. And so the whole system is not very well set up for this because everything is sort of scheduled in and doesn't necessarily account for patients' need for follow-up. And so this is born of sort of a need to figure out how we can better match patients' needs when they need them for the care, as opposed to just, scheduling things in ahead of time. And so this requires like a rethink of how we actually develop and design a care model for arthritis. And so the first phase of this project is really to work very closely with patients, healthcare providers, and also primary care specialists who may be also helping in the care of patients living with arthritis, and trying to define what this care model might look like. What are the supports that are needed to make sure that we can adequately support patients in between visits? If we need to have more urgent follow-up visits, do we have the space and capacity to do that? Is there some type of triage process that needs to happen? Is there connections with, with nurses or other allied health providers involved in this? So it's really to kind of understand and map out all the pieces that are needed, leveraging some of the already, great work that's ongoing in our various provinces. For example, in Alberta, we have something called Specialist Link, where physicians can talk to healthcare providers, like in rheumatology specifically, but also other kind of care providers to get advice in between visits or to help expedite care if they have questions, to help manage patients and provide better access and care. There are also various care pathways that are available to help manage common conditions and questions. And we have a nurse-led model here where we have nurses who support patients with telephone calls in between visits. And we've also had some experience doing even text-based messaging with patients in a model led with our pharmacists. So I think there's a lot of pieces. We just need to kind of put it all together, put the patient really at the center and figure out what the needs are and how we can best meet them, and then kind of redesign the care structure to best meet those needs, while ensuring that our population and the limited resources that we have in rheumatology are meeting the needs of our patients. So hopefully that gives a bit of a sense of like that's sort of our first piece of our project, which is probably going to happen over the next year in collaboration with all those partners. And then the second piece is really to pilot it and test it. And when we have these big changes in healthcare, what's really important is to do a formal test to evaluate the impacts. Make sure before we spread this out or create some kind of widespread program, to really evaluate and make sure that we're using good science to implement and evaluate this new intervention. And a novel part of this is that we're working with another scientist by the name of Sarah Mansky at the University of Calgary, and she does bone imaging. And so one of the things we wanted to kind of test is whether or not there's any change, beyond the patient experience and all these things that we're going to be measuring the patient and provider experience. But actually, if we have a different way of following people, or are we going to be noticing any difference in, say, in the joint health, really? So looking at any erosions that have developed, and she has a very sensitive mechanisms that are beyond just regular X-rays that can be used to measure this. So that's also just a little bit of a pilot that we'll be doing on the side of this that adds a bit of interesting kind of rigor and science to kind of really make sure that perhaps seeing people in different ways is as safe and is not creating any extra damage to joints along this potentially new pathway to care. So happy to answer any questions around that.
Dr. Barber, like I'm just ecstatic. I am so excited for this project because I was just thinking to myself the other day. So I broke out in pretty bad eczema over my entire body out of nowhere. So I live with inflammatory arthritis about a week ago. And I was thinking to myself, like, I don't have another rheumatology appointment for 7 months because I had mine about 5 months ago. And I remember just when I had my appointment 5 months ago, I was just like, oh man, like this is almost a bad time to come to my rheumatologist because I was feeling great that week. My skin was fantastic. I had no problems, feeling super energetic. So I just had a really good month. I saw her during a good month. So I had nothing to report to my rheumatologist. And then I really do think that this is just going to absolutely not only change like the quality of care, but like put patients at ease. I just wanted someone to tell me I'm going to be okay. I just can't wait to see what you find.
Yeah, no, we're really excited. And again, it's going to be a kind of a big collaboration amongst everyone. And I just wanted to put a shout out to Deanne Lakai and others. Have another grant that has sort of a similar bent. And again, just many of us are collaborating across the country really to try and figure out ways to bring patient care to when they need it most, right? That's what we all should be doing, and supporting patients when they need it most, not when it's convenient for the physicians to see people when they need it most. And so, yeah, I'm really excited about this as well, and we're working hard. Yeah.
Wonderful. Well, I do think this is really going to save a lot of downstream effects and move everything upstream. So yeah, excited to see what comes of it. My next question for you, as a trainee in research, I'm interested from your perspective, do you foresee any challenges? I know, you haven't quite gotten started on the pilot, but any challenges, barriers that you foresee?
Mhm. Well, I think with any kind of implementation of a new way of doing things, you know, because it's a change, and especially the way that healthcare is organized, people get very set in their ways. I'd say, especially on the physician end, but potentially it's possible. Some people may, prefer to have something scheduled as opposed to, you know, calling somebody on demand, and they would just really rather have that scheduled. So I think it's going to be really about understanding people's preferences, and this is where the qualitative work. So when we actually go and talk to people, we have questions looking at very specifically to identify what the potential barriers could be. One of the real things that can be a challenge is if we move to such a system where it's more when patients need it. I think we need to make sure that we're adequately meeting the needs and that people are not having ongoing joint damage, which again, why my colleague Sarah Mansky and actually reviewing that, because there could be a danger in some folks just perhaps choosing not to be seen for whatever reason, or it's less convenient, or they feel a barrier to reach out to connect, and that could lead to further joint damage. So we have to be very mindful of supports in place to make sure that that doesn't happen. And then on the physician and healthcare provider side, if often what we're doing is less sort of regular follow-ups, but more people who are struggling or have a crisis, that it may contribute to burnout for physicians. There's a huge rates of burnout in our profession. We recently did a kind of a survey of rheumatologists across the country. Now, granted, this was just in the sort of midst of the pandemic, but there were a large number of people who were identifying that they had burnout, which was, can really impact people's quality of care, their ability to perform. And so it's something we also have to be attentive to as a potential consequence of such a model if we're bringing the more acute kind of issues, into everyday clinic and not having perhaps some things that were more straightforward to manage. So I think all these things we need to think about, but I don't think any of them are insurmountable. They just need a really careful, thoughtful approach to work through. And again, starting with a pilot and really evaluating it to make sure that, that this is, safe and appropriate, equitable, that we're, providing the very best care. And that we also already previously developed a lot of frameworks for monitoring and measuring the care that's provided. So we can kind of keep tabs on that as we go to make sure that the care is, it should be as good, if not better, than the care that was previously provided in the old model. So so that's an excellent question. Yeah.
And I feel like you've really thought this through, because that never occurred to me. Yeah, you're right, because you're getting these incredibly caring rheumatologists having patients. Like, I'm almost glad I didn't talk to a healthcare provider on the day it happened, because I would have been, frantic. But to have, them be in contact with perhaps a patient whose heart rate is elevated and they are in a state of higher stimulation because they are, I don't want to use the word anxious, but something has happened in their life that has caused them to contact their rheumatologist. So really, really well thought out. Yeah. And can I ask, it just seems like such a fantastic idea. I just don't know why we haven't thought of this before. And do you think there's a role for this intervention with other conditions, perhaps?
Yeah, well, the kind of more on-demand care model. First of all, some people, I'm certainly not the first one to have thought of this. There have been like a number of other trials and so on of these types of care models where sometimes they're patient-initiated care models and versus on-demand. Again, there's sometimes a bit of different terminology that's used. And there's been studies mainly in Europe, and there's been some published randomized controls in rheumatology. And they've, we've actually just recently done a review with one of my students. So we hope to kind of publish that, and that will help inform kind of some of the main pieces of some of our understanding in AIM-1 that we'll be presenting to our kind of stakeholders through this process. I'd have to say, I think that this, more on-demand care happens all the time with primary care. So we're often, going to primary care when we have an issue, when we have a need. And I think that's probably very familiar to primary care physicians. And then there may be, you know, the occasional scheduled routine follow-up that might be just for screening and so on. But you know, that's how that operates. And I think there may be a move for long-term cancer care, for example, as well. You know, and for many chronic diseases where you know, we deal with a limited healthcare resource. We want to make sure that we're using it in the most effective way possible to meet patient needs. So I don't think this is a new concept, and I think we may start seeing more and more of this, you know, across, you know, different specialties. We just need to make sure we do it thoughtfully, and then it's not coming from pressure from above, you know, just because we don't have the workforce to start perhaps, you know, discharging patients, which I don't think is appropriate, because you know, that may lead to undue consequences for patients who have an established diagnosis, say, of rheumatoid arthritis. We know that many people, if they lose follow-up with the rheumatology clinic, from work we've done in Ontario, in Alberta, and BC, that if you lose contact with the rheumatology clinic, the rate of people being on appropriate therapy, like disease-modifying treatments, drops dramatically. So we do think that there is a role for this ongoing kind of contact, but perhaps just, again, better matching that to the individual's needs.
Yeah, absolutely. Having an incredibly like tailored, thoughtful approach, as you mentioned, is the most important thing. And can I ask, out of interest, what has, you know, this project taught you so far through the development phase?
Through the development phase. Oh, that's you know, a tremendous question. I think I've spent a lot of time, like, personally learning about implementation science. And I think that this is something that I think is increasingly important. And certainly when I was doing my PhD training, probably, you know, perhaps it was the courses that I was taking, or maybe I was more focused on all the, you know, biostatistical stuff. But like, you know, when it comes to actually figuring out how to translate and think about you know, innovation and how we bring it from a research project into the healthcare system, having appropriate implementation science frameworks to think about this and to test and to evaluate is critically important. And I think that that's a piece that I've spent a lot of personal learning trying to kind of understand, and working along with experts and individuals in our team to, and it's I think that's, you know, that's sort of an area, I think, of tremendous growth and importance that I'm not sure that everybody appreciates. It's not just thinking up an idea and then putting it into practice. It's actually has to be a really thoughtful step-by-step process of continuous evaluation to make sure it's going the way that is intended and doesn't have any unintended consequences that could be missed.
Absolutely. And you know, they say it's iterative. Implementation science is so incredibly iterative, but it sounds like, you know, you've really built yourself a multidisciplinary team. You have patient partners on board. You've done a review. There's a pilot. Like it seems like very much so, like, incredibly thoughtful, well thought out.
Thanks. Yeah.
Well, with that, Dr. Barber, you know, thank you again for your time. We are so excited for you, so excited for this research project. And yeah, we hope to see you again on Arthritis at Home. If not, we hope the pilot study goes well and you learn lots of new things.
Thank you. It's every day is a learning experience, and I'm so grateful for the opportunity to talk about this work. And please reach out anytime. I'd be delighted to speak with you and your network at any point. Okay.
Thank you so much. With that, thank you everyone for joining us today. Goodbye.